Okay, so let's move on. So just respiratory distress syndrome in general, similar to ARDS, it's going to take on the same kind of appearance on the baby's x-ray. And they always refer to this as a ground glass type of appearance. Kind of looks like the glass that you can't see through clearly. You can see something behind that glass, but you can't really detect clearly what it is. And in BPD, and again, these things are introduced here, but then we'll talk about them in more detail in the chapter 22. The respiratory distress syndrome could end up getting worse over time, and then the baby can end up with a chronic problem, which will be known as the BPD. So bronchopulmonary dysplasia would be similar to like COPD for the infant. Now, if the respiratory distress syndrome does end up developing into something like BPD, then that's when you're not going to be expected to see the same type of features, meaning that you don't expect to see the classic ground glass type of appearance, but you could get a lot of air trapping. Just like, again, like COPD, they can end up with like air trapping or atelectasis or a combination of both. And if it, say, ends up being air trapping, first of all, this baby is not intubated. See the trachea. So there's the trachea, there's the right bronchus, and the left is over here. No ET tube. All I see is just that feeding tube, or that OG tube that goes into the stomach. But here, I do see an ET tube. So here is an ET tube, the radiopaque line, and then the other side of the tube, the other border of that tube. And look how everything, here's the spine, look how everything is forced to go to the opposite side. All of this is air. So this is a classic pneumothorax kind of a situation. Is a tension pneumothorax, and it's pushing everything, the entire mediastinum is being shifted to the opposite side. And this left side is not doing that well either as far as aeration. I don't see a whole lot of dark. I see a lot of white, but I don't see a lot of dark. So this is definitely something that would have to be treated. And it looks like there's a chest tube that's in already. That line right there, that dark line that's on top of the ribs, is a chest tube that they have inserted that they're trying to treat this baby. And yes, so with the BPD, it could lead to worst case, like a tension pneumothorax, is what this picture was all about. And then also the baby has some significant atelectasis on the left side because of all of the white that's going on. So not only could your RDS become BPD, but it could also cause air leaking. And we have what's called pulmonary interstitial emphysema, or PI for short. So pulmonary interstitial emphysema is just that. You've got air that's now leaked out of the airways, and it's made its way into the interstitial spaces. And air always shows up as dark. So when we look at our film, we see all these little tiny pockets of air, these little tiny bubbles, and they all show dark. And the same would go for pneumothorax. It shows it's dark, but pi is going to look definitely different from, say, like a pneumothorax. So like in the X-ray on the left, for sure, these little bubbles appear to be all over the place. And again, this is in the interstitial spaces, and this is how it will show up on the film. And again, it could have all been because the baby started off with respiratory distress syndrome and got worse. And we'll talk about in the next chapter how a lot of this could probably be avoided, but then some of it can't be avoided. And then the X-ray on the right is also showing, this is showing a combination. This is an unfortunate case of the air leaking, the air leak syndrome going on here, the pi, and a pretty bad pneumothorax. So you see this is still lung, and then this is all dark. So this is the pneumothorax here. And the left upper lobe. So back to the image on the left here, look at the ET tube. So here's the radiopaque line. And then there's the other edge of the ET tube. And there's the right clavicle. And then there's the left clavicle. The left clavicle looks to be broken. But a lot of times that's not a big deal because those bones will heal. They won't necessarily need to have surgery or be placed in traction or anything like that. But this ET tube looks to be way, way too high. And that's probably because if you can make out the baby's head position, this looks to be the chin over here. So in other words, it looks like the baby's looking to his left. And again, the ET tube will move, it'll shift, depending on whether the head is being flexed or extended, or even move from the left to the right. So I imagine that had this baby's head been in the center position, like it was supposed to have been, then the ET tube probably would have looked like it was in the right position. But for right now, we just have to look at this and say, no, this tube does not need to be pushed down. The baby's head was just in the wrong position. And again, with this kind of stuff, when you're looking at it on a daily basis or like on a regular basis, it gets a little bit more obvious and it gets a little bit more clear for you. So looking at things like this for the first time and me identifying them as the problem, don't feel like you should have been able to recognize that that was the problem and that then it shows up pretty clearly. Just kind of, again, just look at how we just have to say that there could be a possibility. So we always have to think about the possibilities. There could be a possibility that this ET tube was in the wrong position because maybe the baby's head was in the wrong position. And then the one on the right here, here's the ET tube, here's the radiopaque line. And then there's the other edge of the ET tube here. Can't draw this line too clearly or follow it. So somewhere around there. Right clavicle, left clavicle, this looks to be fine as far as ET tube position for this baby. And then once again, here's that long straight line that's going right into the stomach. So this has got to be the feeding tube or the oral gastric tube, OG tube. But then I wanted to bring your attention to some other things that are showing up on this film. So this right here just looks to be your standard like EKG lead, the little tabs that you stick on the skin. So no big deal there. But what is this white line? And then what is that white line? Let me find another color to make it a little bit more distinct. Here's a white line. And then let me find another color. And here's another white line. All right, so I see UVC. So, oh, and I'm sorry, Indira, I didn't look over when you were asking if ground glass is different from honeycomb. Um, Honeycombing and ground glass can go together. They could possibly be pretty much the same thing, but ground glass is not necessarily going to show you a honeycomb pattern. So in other words, you could possibly see some ground glass with honeycomb type of lung problem, but in general, just respiratory distress syndrome, ARDS doesn't usually show up as that distinct honeycomb pattern. When we look at some of those other lung diseases, like the interstitial lung diseases, they for sure will start to take on that kind of pattern. So I guess to that's just to say it depends. I mean, it could or it may not necessarily. So I wouldn't want you to automatically assume or automatically associate the two and say that they can just be used interchangeably because it really kind of depends on the pathology. Now, Georgie, which one of those you feel is the UVC? The blue one or the purple one? Think about your anatomy and let your anatomy guide you. Which one of those you think is the actual UVC? Is it the purple one or is it the blue one? Right, the purple one, because that is where you would expect to find the inferior vena cava. It'll be somewhere on that side. Now, granted, the baby's position may not be, again, he may not be lying flat on his back. He may not be lying completely supine. He might be kind of rotated a little bit to his left. And another thing that can kind of guide you on the rotation, if one clavicle looks a little bit shorter than the other clavicle, then there's got to be some rotation going on. I can't really detect. Here's the right clavicle. I can't really tell what's going on with the left clavicle here. But let's just say that this left clavicle ends up looking a little bit shorter than the right one. Then that would suggest that the baby's kind of like rotated on his side a little bit. And then that would probably explain why this SVC, or not SVC, inferior vena cava, why the inferior vena cava, instead of being on this side of the spinal column, it ends up being a little bit almost center. But again, blame that on probably the rotation that's happening right now. So that obviously means that if this is the UVC, because that's the inferior vena cava, this has to be the, where's the blue? This has to be the UAC. And remember, they will insert these umbilical artery catheters and they'll either be at like a higher position or they'll have it at a lower position. But a lot of times, if they insert it at a higher position, like in this region here, it'll be very clear that this has got to be the UAC and that's the UVC. Because the UVC will never be inserted at a higher position like the UAC would. It'll usually always be at a lower position, more around the lumbar region. Okay, so good job recognizing those lines there. So that's all we're really doing is we're looking at the film, first of all, for obviously problem areas, things that just don't look right. And then we start looking at all the other things to say that this has got to be the ET2. And by the way, always look for the ET2 placement first. Always. Don't start looking at other stuff until you feel good about where your ET tube is sitting. And then you start looking at all the other things like, well, what's this and what's that? And what does this got to be? So this big round circle, this is not part of the baby's anatomy. This is just one of those leads that, you connect to the monitor. Same goes here. This isn't a spot that ends up that's on the baby's chest. This is actually another lead that's there. So Identifying the artifact would probably be the last thing that you'd want to do. Unless you were shooting the film like you were the person who did the procedure and you wanted to see where everything ended up, like say you were the neonatologist and you just inserted this UAC and this UVC. Now you get an x-ray and that's what you're looking for to make sure it's in the right place. So just be prepared for your board exam. They give you pictures, they give you x-rays, and then they ask you questions about what's going on with that particular patient. Like, is there a chest tube? Are they intubated? Are they trached? Do they have a UAC in place? Is there a UVC in place? You know, things like that. So it's kind of like they just want you to be able to spot objects that show up on these films that clearly aren't part of the patient's anatomy. Okay, and PDA, so patent ductus arteriosus. You know, I know that there was really no proper order to cover these chapters as far as do we cover the diseases first and then cover the x-ray chapter, or do we do the x-ray first and then the diseases? It doesn't work out too well either way, because they're going to start introducing all these different lung problems in this chapter. And then when we get into the diseases chapter, then they start to assume that you already understand what's going on with x-rays. So this is a PDA, or patent ductus arteriosus, and you probably already knew this from your cardiac anomalies chapter. So with the PDA, it's not an exact lung problem per se, but it is going to lead to some problems as far as pulmonary. So with this issue, as they're saying here, it can be placed, it can be like right on top of the RDS. So superimposed, meaning like you've got RDS, and in addition to RDS, on top of that, the baby's also got a PDA. And then when you have that kind of combination, for sure, you're going to end up with cardiomegaly. So look out on the left versus the right, where the right, the entire thorax looks to be just hard. And what you have to do is, of course, they would never just give you the x-ray and say, is this a PDA? And there's a big heart. I mean, it could be so many other things going on, but you have to know everything else as far as the baby is cyanotic and the baby was just born and blah, blah, blah. So all the risk factors would have to be there for, say, for someone who's developed a PDA. And then just going through what we can detect here. So there's the ET tube. So notice how the radiopaque line is here. And then the other edge of the ET tube is here. Now, why in the world is this tube way over here? Here's the spine. Here is the right bronchus, and this is the left over here. So as far as between the clavicles or slightly below the inferior border, it's good placement, but it just looks to be that everything is pushed over to the right. So if that's the case, are we saying that there's a pneumothorax on the left side that's pushing everything away? Or again, is it the baby's position? Probably the head, the way that the head is being positioned. And then looking at the clavicle. So there's the right clavicle. That right arm looks to be extended this way. And then there is the left clavicle. And it looks like that arm is maybe like up here. So again, it could be a little wonky when it comes to babies in their ET2 position based on x-ray, because it'll be highly, highly dependent on their position. And again, help your x-ray technicians out, because they definitely cannot do all this by themselves. You have to ensure that if you want to get a good film, you want to get the best possible film that you can get. You secure the baby, you hold the head, you keep the body midline, you do all of this stuff while you shoot the film. It only takes like a couple of seconds once they get the baby positioned correctly anyway. And then when you get your results back, you can now see, okay, this ET2 really is in the wrong place. It needs to be pushed down a little bit, or it needs to be pulled back a little bit, because I know that I had the baby in the perfect position. The head was centered, his head wasn't being flexed, it wasn't being hyperextended. His overall torso wasn't rotated. He was centered, midline. And now for sure I can determine what I need to do with this ET2. But for this example here, again, it looks like I'm thinking baby's rotated again. It looks to be that way. Now, the one on the left, I'm sorry, the one on the right here, is this baby intubated? Can't really see anything. It's just so white. There's so much it looks like there's too much overexposure going on. I'm sorry, underexposure going on here. And there's something that's white, but I'm thinking that this is just your standard feeding tube or OG tube that's going into the stomach. So I don't really see anything that looks to be a radiopaque line. And that could be possible because not every baby who ends up having a PDA will be intubated. They'll just be on oxygen, or maybe they'll be on CPAP or something, and then they get diagnosed with the PDA. Now, meconium aspiration syndrome, or just MAS for short. But I will say this, when we get into the next chapter, that it will go pretty quickly because we're already introducing these like lung problems. So meconium aspiration syndrome, you're thinking air trapping mostly with this problem because you've got this stuff that's in the airways that's preventing the lungs from emptying. So the air may go in, but it will have a hard time trying to leave. And then you get the air trapping. So you got the meconium itself that would show up as white because it's a solid type of material and it's going to absorb a lot of the X-rays, and so it shows up as white. So they're saying patchy opacity, so a lot of white stuff, and that's usually secondary to atelectasis. So it's a combination of a lot of things happening with meconium aspiration. So on the X-ray on the left over here, there looks to be an ET tube. I'm going to put a question mark. Is this baby or this child intubated? So this right here looks to be and then there's a classic feeding tube. And there is a UVC. And these are, of course, these are just our EKG leads, 3 leads. This device is a transcutaneous oxygen and CO2 monitor. And we're going to call it TC PO2 and or most of these monitors are going to show both at the same time on the screen, or TC PCO2. And this just stands for transcutaneous. Another non-invasive way of trying to track what's going on with the PO2 and the CO2 without having to do an ABG. And this right here, Uh, it's a little weird, but this is the outside of the UVC. So as the UVC is going into the umbilicus, and then you can't tell like what's going on down here, but then eventually you do see the tip of the UVC right here inside the inferior vena cava. Now this baby does not have a UAC. And then we look at all this like white patchy looking stuff here. I mean, we got a lot over here. There's a lot going on over here. So then this is like what is being described as the asymmetrical patchiness that you would typically see with meconium aspiration. And then notice that down here, there looks to be maybe a pneumothorax that's starting to happen. So there's some air trapping going on here and here. So here's some air trapping. And then down here, it looks to be some air trapping that's going on. And then on the right, so more of the same. Lots of patchy, lots of possible atelectasis, and doesn't look like this baby's intubated. I can't tell. I don't know what this is right here. I don't even want to even begin to try to speculate what this could be. At least this looked like it was in the actual airway. This doesn't look like, it looks like it's too far away to even be considered maybe an ET tube. But look at all of this air trapping. I mean, look at this big pneumothorax, I should say. All of this is air trapping, or now we're going to definitely say a pneumothorax. And then this right here is a chest tube. Now with chest tubes, you're supposed to be able to see like a little like almost like a broken line. Like it'll be white and then it'll be a gap and then it'll start showing white again. But it's kind of hard to tell. It's really hard to see where that is on this. It's kind of getting silhouetted with all this other this patchy stuff that's going on with the meconium. Now, congenital diaphragmatic hernia. We saw an example earlier where the feeding tube was way over here. So then this is usually pretty clear because you know there is nothing that's going to, nothing else is going to resemble this. Is what CDH is all about. If again there was an area of the diaphragm that was weak and this could have happened in utero. It usually does happen in the early stages of fetal development. The diaphragm develops pretty quickly, but if there were certain areas of the diaphragm that never closed off like they were supposed to, then that just meant that the chances of the bowels pushing through that opening were pretty great and pretty high. And that happens. I mean, so then this is an example of the diaphragmatic hernia being on the left side, but it can show up on the right side as well. It doesn't matter which side it ends up happening, but it can present either way. Now, let me see if I can try to explain what's going on here. Because if you look at this and you say, is this the ET tube? And then is this another ET tube? It's kind of odd, but you know there's no such thing as having two ET tubes inserted into the airway at the same time. So if you look closer, there is it's hard to tell, but there's a gap right here. So here's the radiopaque line. And then there is a gap, and then there's the rest of it. And then there's the other end, there's the other border. And then this, as you see, is just no breaks at all. It's just a continuous straight radiopaque line, at least here, and then the other edge of the tube here. This is the ET tube right here. This is the feeding tube. So with your feeding tubes, OG tube, they will have that little gap as well. So that way you can kind of distinguish it between, is this an actual OG tube or is something else that doesn't have that little pre-designed gap in the radiopaque line. Kind of like with your chest tubes when they have that little gap as well. But yeah, they inserted this OG tube as again, kind of like a diagnostic kind of thing to see when they shoot the film, where does the OG tube end up showing? And you know, it says here NG, but with babies, they do not usually insert that feeding tube into the nair. They usually do it through the mouth. So they call it an OG tube for that reason. Now, anything else that we could say about this? Well, first of all, why is the ET tube so far down? Look at the baby's head. Now here it's definitely clear that the baby's looking over his right shoulder when he's laying there. And as far as like rotation, he's also possibly rotated because there is the left clavicle, and then this looks to be the right clavicle, and it's way shorter, and is even angled upward. So then you have to ask yourself, how did these pictures end up getting taken like this, where your baby's just like head is all in the wrong position and he's rolled on the side or on the other side? Was it a fussy baby and they just had a hard time trying to get the picture? Or was it just that this was the x-ray technician not even asking for help, just trying to do it themselves, knowing that they can't hold the baby in position and operate the machine at the same time? That's always a mystery to me when I see these kind of films. I'm always curious, like the backstory, like what happened for them to end up taking this picture where this baby is definitely in the worst possible position ever, which makes it really hard for you to try to make any kind of decisions on what you would need to do. But this was all about just confirming whether or not there's a diaphragmatic hernia. Okay, it looks like it's lunchtime. So I think we're almost done with this chapter anyway, and then we'll just get into the last one here. So it's close to 11:50. So we'll be back at 12:40.